Good morning, everybody, and welcome to the instruction course converting from manual SICS to phaco in a stepwise manner. We definitely understand the importance of it. Entire India is into about 50% phaco emulsification, and the rest 50% has to get the feel of this surgery. And we are learning. Before I start, I tell you that there is a beautiful addition to this instruction course. My guest speaker, Dr. Boris Malaguin, he will be there in the lecture. And Boris, could you come and take the podium for some time? I think it's better to watch from here rather than sit there. But for a moment, please. Boris is the Deputy Director of the S. Fyodorov Eye Microsurgery Center, which is the main hospitals of the Russian Federation. I'm told there are 11,000 ophthalmologists in Russia, and about 3,000 of them are surgical ophthalmologists. They have more than hundreds in training, so quite if we put it to our picture, it will be maybe 1/3. Of course, most of us trainees, most of the doctors here do operate. We don't have this comprehensive ophthalmologist class, not in a big way. So, Boris, welcome to this course. And the need, of course, is getting clearer because our economy is definitely getting better. The patients are coming earlier for cataract surgeries. The machines are getting better, and the technology is becoming more and more Indian by the day. Now, this wow factor, that the very fact that we have not been operated on the first post-operative day, is something that you can only give by as smaller incision surgery as possible. Well, if you look at our own hospital statistics, this would be our total surgeries, and you can see the phaco graph going up, whereas the SICS dipping from 16,000 in 2005 to 2013 to 6,500 for people who cannot afford hydrophobic foldable lenses. Now, the first step to go about this is to go for a wet lab, and it's a very simply arranged wet lab. Your microscope, your phaco machine. You need goat's eye. You can get it from any meat shop, and you fix it on a thermocol block. This eye has to be fixed, as you will understand in the later maneuvers. And once the eye is fixed, you can go ahead and do things like this. I mean, this is our standard SICS incision. Now, you will understand the purpose of doing it like this. Why an SICS incision? The SICS incision is done in the same way. We have to see that this incision is well constructed. The scleral tunnel the corneal valves so that it doesn't leak. Having done that, a separate corneal incision with a little longer valve. We must remember that the goat's eye has a bigger cornea, so if you feel that your probe maneuvers are difficult, then you can actually give this incision slightly more anteriorly and then go in to practice rhexis. Many people would practice rhexis on potatoes, on the cellophane envelopes of cigarettes, but I would tell you this is the best way to practice rhexis because it gives you almost a near feel of doing rhexis in the human eye. You can go ahead and practice the rhexis, and here we are doing this, the onion wheel technique, and here we are doing a smaller rhexis. The purpose of it will be evident. You make a side port, again that has to be closed, and try to simulate the human eye. Then go ahead and do a little bit of sculpting with the phaco probe, and the whole intention is to create a bowl in the soft nucleus of the goat's eye, And once we've done that, you have a lot of SICS nucleus that you have removed from your patients. You can actually harden these nucleuses by keeping them in formalin or to any kind of hardness that you wish to work upon. Then you enlarge and open the SICS incision. You may not open it fully, because all you need to do in this incision is to put the nucleus into that area. Now sometimes these Irish pigments and the Irish would come in between. You can actually skip them off. Now the same SICS nucleus which you have actually removed from the human eye, you do the reverse procedure. You dial that into the eye, into this bag again. And that is why you need to do a smaller rhexis, because it should accommodate this nucleus so that it doesn't spill over. Now your phaco machine is perfectly comfortable to be worked with. It doesn't damage, because if you use phaco externally, the handpiece goes off, and now you can do all your procedures. All that will be taught during the course. Learn how to trench, learn how to divide the nucleus into two, learn how to chop. You want to practice a new chop technique, you can go ahead and do this. So this is the very idea and concept. But I tell you, the more you do it, we have a training program, and we make sure that our trainees do at least 4 to 5 of these nucleuses every day, and it's a 1 month training program. So, and by the time they do about 20-30, this is supervised by our OT assistants. They tell us whether they are good enough to come and start operating under the human eye under supervision. So you can do all kinds of things that is possible. And suppose you want to practice a new technique like a chop. So again, you start chopping from the very beginning. So all this can be done, and I seriously insist that you really work hard on this goat's eye area. Very few people take interest in this, but this is the safest way where you can get to into the act of phacoemulsification, the switch over, without any long complication list. Now, if you can do it right in the goat's eye, you can do it in the human eye. Now, phacodynamics is a very complicated subject. Of course, you need to know a very little bit of it. So I'll just take 5 slides to explain it. Just hear carefully. We have the paddle has 3 steps, and it activates 3 things. The first step activates irrigation. Irrigation is a passive process. It depends upon the bottle height, and of course for the machine, the sleeve size and the bore size, the number of openings on the tube. But for a machine, it is fixed. The more you raise the bottle height, the more will be the irrigation. And it stops when the intraocular pressure is equal to the bottle height. It compensates for everything, what we aspirate, what it leaks. A wound should leak because we need to cool the wound when ultrasound is being delivered. So that's step 1, irrigation on. In step 2, the moment we go to step 2, the motor is activated, the motor is on, and the aspiration flow starts. It is measured by flow in cc per minute. Greater the flow, greater will be the followability, and quicker will be the whole process. So as the fragment flows to the tip gets occluded and there is no aspiration. The motor still continues to rotate, and the tubings, and it draws fluid from the tubings, and the tubings collapse, and this causes the vacuum buildup in the tip. Now, this collapse is measured by the collapse of the tubings and a vacuum sensor which also collapses, which is in the cassette. Now, when it reaches the preset vacuum level, the motor stops. Suppose we fixed it at 200 millimeter of mercury, the motor stops and no more vacuum develops. It is measured in millimeter of mercury. Now the vacuum gives us the holding power for chopping and when we are emulsifying. In step 3, we are delivering energy. So we deliver energy to the occluded fragment. The fragment is emulsified. The moment it is emulsified, the occlusion or the vacuum is broken. The tubings again swell, and the vacuum sensor tells the motor it gets on again, and the aspiration flow starts. So what happens is it is a cycle. The fragment engages again, the vacuum develops, the energy is delivered, occlusion is broken, again the aspiration starts and the fragment engages again. So this cycle goes on. This is what happens in phacoemulsification. The harder the cataract, we use more vacuum to hold during chop, and of course in harder we'll be using more energy, so we need more hold to emulsify it. And when we use more energy, we have to use more aspiration flow, because we are repelling the nucleus, it has to be brought back to the tip. So these are the basic fundamentals. And with high energy and high flow, when we are using for hard cataracts, we can get a surge, because when the tubing suddenly collapse due to the high vacuum, and then because of the high flow rate, there is sudden expansion, lot of fluid will come out from the eye, and that gives rise to surge. Now the energy can be longitudinal or it can be torsional in new machines. The torsional has the advantages that the jackhammer actually hits and there is a repulsion, whereas in torsional the followability is more and there is more excursion in the tip than in the wound. The energy can be pulsed and like the CFL bulb. So there is sometimes the energy is delivered, sometimes it is not, and the heat generation is less without much affecting the emulsifying power. The collapse and the sudden swelling of the tube in the newer machines. What is there? There is those machines look like a rocket launcher, but there are very few things which are different. The collapse, they use less compliant tubings, and for this it requires a stronger motor. And what is more important is they use disposable tubings, because you can see in every throttle that, in one emulsification process it's being throttled a million times. So this compliance of the tubings go wrong, and if you are using the tubings again and again and again, even the vacuum sensor is also throttled. So if you change it for every day, your machine functions become better. So this is all about the new machines. There's no rocket science in it actually. And so this is the basics about phaco-dynamics. As I told you, that this is the irrigation. The more you raise the irrigation, you can follow the irrigation column at the top. The deeper will become the chamber. So this is the irrigation component. The more you raise the bottle height, the more the irrigation will occur. Now let us see the aspiration flow. Here we've kept the tip slightly away and we are raising the aspiration. Now see the aspiration 22, now it goes to 30. The safest aspiration area would be around 25, 30. And now, so the tip engages. Now if you use more aspiration flow, this is what happens. Fragments keep on flying, the iris might come into the tip, so undesirable aspiration flow is unnecessary, and of course the surge. Now this is to explain the vacuum. Our own vacuum cleaner can explain. When we place the vacuum on the nucleus, it can actually, because of the collapse of the tubings, the vacuum occurs. And this is how you chop. You impel the nucleus, see the vacuum column develops, then it stops there, you get a hold and then a purchase on the nucleus, and then you can chop because you have a good hold. See, once the vacuum slipped, there was a little fumble, and then again as the vacuum is held back, again re-impelled, and you can get a good job. So now emulsification, please follow the parameters on the right hand side. You will see how the vacuum is broken and the aspiration goes, again the vacuum happens, again the aspiration, the cycle that I was talking about. And this is chatter. When you are using too much energy without, less vacuum, and so what happens is the energy repels everything and there is chatter. Now I was talking about surge. This is manifested in a cadaveric eye. You can see we are raising the vacuum height to 500, 600, and we are raising the aspiration to 60. We are using a lot of power, and then there you see that, as soon as the occlusion was broken, there was a sudden collapse of the chamber and there was a PC red. Now, machine problem, this is very common when you are using the emulsifying for hard cataracts. If your energy and flow is not balanced, what happens is a bigger chunk goes and gets embedded in the tip or the tubings, and this blocks it. So what you need to do is remove the tubings and remove the tip and get a new tip in, and prime the machine and use it again. So this is about my topic.